The final part of the present series will review the basics of peripheral compartment hip scope. The T-capsulotomy is performed from working through the anterolateral portal to enhance access to the hip's peripheral compartment. It is performed by utilizing the radiofrequency probe and extends distally towards the zona orbicularis to avoid causing iatrogenic instability after the procedure. Multiple sutures are passed with the use of a suture passer to place traction stitches and allow for improved visualization of the hip. By this time, 2 traction stitches had been previously positioned during the central compartment portion of the scope, while additional 2 are placed in the medial and lateral leaflets created upon extension of the T portion of the capsulotomy. Representation of the final positioning of the traction stitches is shown. Femoral cam resection is performed while assessing the cam in a 360-degree manner by fluoroscopically positioning the hip into 6 different positions. A 50-degree radiofrequency probe is utilized to mark the most proximal aspect of the resection at the femoral head-neck junction. The periosteum will be cleaned to allow for the burr to have a clean and optimal resection. The cam is assessed at this point in the previously referred 6 positions. The most lateral aspect of the cam lesion is resected in extension and neutral rotation, extension and 30 degrees of external rotation, and extension and 30 degrees of internal rotation, whereas the most anterior portion is assessed in 30 degrees of flexion in neutral rotation, 30 degrees of flexion, and 40 degrees and 60 degrees of external rotation. A 5.5 mm burr is used at this point to create a trough that will set the depth of the resection throughout the femoral neck. The hip is brought into extension, and the most lateral aspect of the resection is carried out. This is checked with the use of fluoroscopy to ensure that the depth is still accurate. Fluoroscopic confirmation of adequate lateral cam resection is warranted prior to proceeding with the anterior cam resection. Finally, the hip is brought into maximal flexion and the most anterior aspect of the cam deformity is assessed and resected, always matching the depth of resection that was achieved at 30 degrees of flexion. The burr can be used in reverse at this point to smooth out the edges of the bone and create a smooth transition between the femoral head and the femoral neck. As you can see in this cadaveric demonstration, there is significant friction between the cam and the cartilage and the labrum, but when the cam has been resected, there's frictionless motion in this hip, which has returned to be concentric again. Capsule closure is important as it enhances outcomes while both the anterolateral and mid-anterior portals are utilized as working portals at some point. Next, the capsule is closed with the use of a suture passer. We start the capsular closure on the most distal aspect of the T-capsulotomy while viewing from the mid-anterior portal. This is done using a clear path cannula to avoid any suture tangling. We work our way proximal with the use of a suture passer as we take some tension off the traction stitches that were placed previously, which allows us to plicate the capsule even further. Finally, the interportal capsulotomy is closed with the use of the same suture passer while viewing from the anterolateral portal. As you can see, the spaces get smaller here as we work our way up. The capsular closure is checked at the conclusion of the procedure to ensure there is a watertight seal closure of the capsule. It is important to close the capsule in extension to avoid iatrogenic induction of postoperative flexion contracture. This concludes the presented basic hip scope series.